Good morning, everyone. At the outset, I would like to thank AIOS and Dr. Somashila Murthy for giving me this opportunity. I'll be talking to you about OSSN. We all know that it is the most common malignancy of the ocular surface and comprises a spectrum of diseases ranging from dysplasia to invasive carcinoma. Intraepithelial carcinomas refer to superficial disease in the epithelium, only which is generally categorized as mild, moderate, or severe cases. But when the cancerous cells invade through the basement membrane, it is described as squamous cell carcinoma. So these are varied clinical presentations. Here you can see a diffuse flat lesion with feeder vessels. Here it is a gelatinous mass at the limbus extending onto the cornea, a diffuse but slightly elevated limbal lesion with feeder vessels, plus grayish flat lesion involving the cornea, which is known as pagetoid spread onto the cornea. Sometimes there may be a pigmentation with a plaque onto the surface. There could be an elevated mass with keratin and large feeder vessels, a limbal mass with corneal involvement and a lot of keratin onto the surface. Sometimes they present with a very huge area of involvement, late presentation, or there could be elevated mass with keratin and heavy feeder vessels. This case had a grayish lesion over the cornea with indistinctive features, and he had, on probing in detail, he had a history of probably a pterygium removal, which was not a pterygium, and it could have been an OSSN. So these are the cases who would require a map biopsy to identify the disease process. The lesions appear macroscopically as gelatinous, leukoplakic, papilliform, nodular, or diffuse, and they may be flat or elevated with feeder vessels, which may be present or it may be less distinct. Symptomatically, they may be associated with mild discomfort, pain, and irritation. The risk factors associated could be ultraviolet light, cigarette smoking, petroleum products, previous chronic conjunctival disease, chronic contact lens wear, even a Caucasian race is a risk factor, association with HIV and HPV infections, and xeroderma pigmentosa. The diagnosis is most often clinically, although definitive diagnosis is provided histopathologically with either incisional or an excisional biopsy, or other less invasive modalities such as impression cytology, exfoliative cytology, or even a fine needle biopsy, aspiration biopsy have been utilized. A confocal microscopy has shown promising results in the evaluation of ocular surface lesions. However, it requires contact with the eye, and it can, the cross-section would be very small. Recently, anterior segment OCT or ultra high resolution OCT has been very helpful in allowing us to diagnose these cases. Though usually we traditionally rely on biopsy, the OCT demonstrated consistent features to allow the diagnosis prior to the excision of suspicious lesions. Being non-invasive, it provides a cross-sectional evaluation of the lesion, and thus in a way an optical biopsy with a resolution between 2 and 5 micron without the need for direct contact with the eye. This is especially important because there is an increasing use of medical therapy. It helps us in diagnosing subclinical cases and at times incomplete therapy of those cases. OCT can potentially provide a non-invasive means of diagnosing, differentiating neoplastic epithelial lesions, particularly in the setting of a concomitant ocular surface disease. The corneal OSSN and corneal pannus can both present with clinical findings of an opalescent lesion and may have an overlapping finding on HROCT. Both the entities may show epithelial layer reflectivity, increased epithelial layer reflectivity on OCT. OSSN demonstrates an abrupt transition at a very vertical area, that almost 90 degrees of an angle, whereas pannus would appear as an angle transition around 45 degrees. Therefore, the angle of transition between normal and abnormal epithelium can be useful in distinguishing these features. As you can see here in a clinical photograph, where there is a superficial flat opalescent OSSN on the left side. On the right side, the OCT reveals thickened and hyperreflective epithelium with an abrupt transition point as shown by an arrow. As I said, it is very important that we can differentiate between subclinical cases. Here is a clinical case where there is a pterygium as well as OSSN associated with that, and you can differentiate the two with the help of HROCT, and even you can decide the endpoint of your treatment. So HROCT confirms normalized thin epithelium and subepithelial scarring which is consistent with only pterygium in the last slide, as you can see, last picture, as you can see here on this OCT. The management algorithm for OSSN would include local immunotherapy, chemotherapy, chemoreduction, surgical excision biopsy with other adjuvant therapy, resurgery or immunotherapy, plaque brachytherapy, enucleation, and orbital exenteration. The treatment has changed significantly over past 2 decades due to a greater understanding of the disease, improved diagnostic capabilities, and a shift towards the medical management of these tumors. We'll just look at some clinical scenarios. Here is a 60-year-old female presented with whitish lesion on the eye, redness, pain, and watering for 3 weeks. As you can see here in the clinical picture, there is a grayish pannus with at the limbus with vascularization. They are better delineated on red-free filter. And this is the clinical picture after 2 cycles of topical 0.04% MMC eye drops. You can see that lesion has almost resolved just on medical management, but you can reconfirm that on OCT whether there is any subclinical disease present or not. This is another case where this patient presented like this. Received, we gave 5FU 1% to this case. This is the second clinical picture after 1 month, after first cycle of 5FU. The third shows that almost the lesion has disappeared. But here also the OCT would help us in deciding the endpoint of your treatment. Surgical excision remains the most important treatment option in the management, especially in elderly patients with poor hand-to-eye coordination or where there is a cost of long-term therapy and frequent follow-up is an issue. So extensive surgical, the downside is extensive surgical excision can result in limbal stem cell deficiency, scarring, and sometimes symblepharon formation. So before, like the steps of surgical excision, one should be doing a thorough clinical examination to decide the extent of the tumor. One can use a rose Bengal dye for better delineation of the tumor, documentation, and both clinical and pathology. Photographic is very important. A clinical diagram and plan of surgeries also will help you on table. A wide excision beyond the clear margins, that is 4 mm on the conj side and 2 mm on the corneal side. One can do an alcohol epitheliectomy from the corneal side, cryotherapy to the conjunctival edges and veins if that is needed. A histopathological examination of the biopsy specimen is must, and it should be labeled properly and spreaded properly to have a post-operative information. Sclerectomy, when there is an involvement of the sclera, can be performed. This is just a small 30-second video which just explains how we go about it. A 4 mm area is marked on the conjunctival side and 2 mm area on the corneal side, and you can do an alcohol epitheliectomy. You can literally roll the epithelium from the surface, and without actually touching the tumor, you can remove the tumor intact. And the same lesion can be spreaded over to a Whatman filter paper and labeled properly so that the pathologist can tell you the involvement of the edges. And the area is covered with the amniotic membrane at the end. This is another case where she was diagnosed to have an extensive pterygium. And on examination, if you do a dilated examination, one can even delineate the corneal lesion here very clearly. I'll just take a minute. So this particular patient needed chemoreduction, but it did not respond completely, so it was followed by an excision biopsy. So by doing a chemotherapy, you can reduce the size of the involvement, and then probably your surgical excision would be smaller. So this is the histopathological slide showing classical squamous cellness on histopath examination, and it turned out to be an infiltrative squamous neoplasia with keratin onto the surface. So if there are positive surgical margins, a re-excision is advised, or even a topical chemotherapy or immunomodulation can be tried. Paper from Bascom Palmer talks about treating these patients who are having positive margins or negative margins. They would like to use topical immunotherapy for 2 months. So that is their protocol. So advanced disease or multiple recurrences despite aggressive treatment may require sometimes extensive surgery in the form of enucleation or orbital exenteration. These patients need to be followed for 3 monthly for first year, 6 monthly for second and third year, and thereafter yearly. If the patient shows any signs of suspicious lesions, the management can be modified. This is another example where there is a diffuse involvement of the cornea and the limbal and the scleral region. You can see that very well onto the red-free filter pictures. She received 3 cycles of topical MMC 0.04% eye drops, 2 weeks on and 2 weeks off. Responded well initially, but later the lesion it had to be excised. So if we look at the first initial presentation, the area of involvement was much larger, but after chemo reduction it has become very small, and your surgical excision would be smaller in size. So this table just explains about various modalities of treatment which we can use. In our scenario, MMC and 5FU is easily available and cost effective, but one can also use interferon alpha 2B when it is not responding to MMC or 5FU. There are other therapies, photodynamic and plaque brachytherapy. The factors such as star cell involvement, positive pathological margins, and higher pathological tumor grade, they have been implicated with higher recurrence. In refractory OSSN, chemotherapeutic agents can be used either sequentially or as a combined treatment. So just to end my talk, the take-home message here would be clinical and photographic documentation and NTA segment OCT is very important for these lesions. Careful management planning and optimal use of treatment options, including multimodal treatment, can result in minimal recurrence and probably avoiding complications. The compliance to the therapy and follow-up are the key to the success of this overall. So if availability and compliance is not the issue, it is best to use topical interferon in these cases. Thank you.